for joining this webinar arranged by the ERA-EDTA on COVID-19. My name is Kate Stevens and I'm a nephrologist from the UK, and I'll be moderating this session. So I'm delighted to introduce our panel, and I'm exceptionally grateful to all of them for agreeing to take part. And that's not least because some are self-isolating and others are really at the forefront of this pandemic and working on the front line under exceptionally challenging circumstances. So particularly Umberto Maggiore, who's been doing night shifts all weekend and has very kindly joined us this afternoon. So we have Professor Umberto Maggiore from Italy. We have Professor Maria Soler from Spain. Now, her presentation, she's been assisted by Professor Nuria Fernandez Hidalgo, who's an infectious diseases physician, but unfortunately she's very busy and has been unable to join us this afternoon. We have Professor Annette Brookfield from Sweden and Professor Paddy Mark from the United Kingdom. So a little bit of housekeeping just very quickly. It'd be very helpful if you could mute your microphones when you're not speaking so there's no interference. We prepared 3 short presentations for you, and that's been on the basis of the questions that you've sent in. So we've had huge numbers of questions, which is terrific. And I hope the presentations will help to maybe not answer, but at least address some of the questions. And after we've heard those 2 presentations, we're going to have a general discussion and try and cover some of the other questions that we maybe haven't covered in the presentations. We are going to organise another couple of sessions, so I'm hoping that over the course of these webinars we will manage to address everything. So first of all, I would like to ask Professor Annette Brookfield from Sweden to present her talk on essentially the publications. I think we're all very keen to try and provide some kind of treatment for our patients. I guess the emphasis has to be on doing this in an evidence-based fashion if possible, and not maybe jumping to conclusions. So Annette is going to go through the literature that we have so far. Thanks, Annette.
Okay, can you see my slides now?
We can.
Okay, good. Okay, so my talk is about some implications for nephrology, what we know so far. And we all have heard about this virus, and that it's quite contagious, and it also can we can transmit the infection from asymptomatic contacts, which has been shown in the different publications. The natural history based on the WHO China joint mission is shown that most individuals have a mild to moderate infection, then are severe disease in a subpopulation that is quite large, and critical disease, and this has been shown repeatedly in several countries. And what we can have done so far is just to try to lower and delay the epidemic.
And sorry, could I interrupt for 1 second?
Yes.
Could you make it a presentation? I think it would be easier to see the slides.
Oh, okay, sorry.
No, don't apologise.
Yeah, okay.
Thanks very much, thank you.
Okay, can you see it now? Yeah. And the natural history, and then what we've done so far is to try and lower and delay the epidemic peak, more or less success in some countries and less of a success in other countries. So, and for CKD as a risk factor, there are several publications, and one of the problems, I just want to say that right now, that most of the publications are preprint, so it's been really quick the way they are presented, and they are not been peer-reviewed in a proper manner, but this is what we have right now. And this is from a meta-analysis from China for severity, showing that the predictor for disease severity include old age, male is at high risk, smoking, and any comorbidity where chronic kidney disease is quite prominent. Chronic obstructive pulmonary disease and cerebrovascular disease is also common as a risk factor for severity. What about kidney as a target organ in COVID-19 infection? So what we know from previous literature in SARS and MERS coronavirus infections, that acute kidney injury is quite common in some cases, and that is also associated with a strong mortality risk previously. In COVID-19, proteinuria hematuria has been reported as a finding of admitted patients, but the significance is unclear. And I'm just sharing the literature here, where you can read yourself, Kidney International, recently published, and also very good summary of literature and the discussion on the NEFJC webpage about COVID-19. So this is a study from China looking at patients admitted to hospital and looking at kidney disease as a risk for in-hospital death. And these are 708 patients, male more than half, severe 40%, and with comorbidities of 40%, and a 16.1% of in-hospital deaths. And the prevalence of kidney abnormalities in these patients with elevated serum creatinine, GFR less than 60 in 13.1%. Quite a common finding is proteinuria and also hematuria and AKI 5.1%. And this is looking at the outcome, and the proteinuria, especially high levels of proteinuria, is associated with in-hospital death, and also AKI different stages that are associated with high risk. So they want clinicians to be more aware of CKD, kidney disease in patients with COVID-19. So the mechanism of kidney involvement is not really clear. It could be multi-organ failure and shock, and also the cytokine storm that has been at the front of the mortality. Also, there could be direct infection of tubular cells, and it has been shown that COVID-19 binds to the ACE2 receptor to enter cells. And ACE2 is abundant in podocytes and proximal tubular epithelial cells, as been reported in this preprint study as well. And from Wuhan in China, they have described a patient cohort of 85 patients, and 23 of those had AKI. And they also had done post-mortem in 6 patients of kidney tissues, showing severe ATN and lymphocyte infiltration. Immunohistochemistry showed the signs of the antigen, the SARS-CoV-2 antigen accumulated in the tubules. And there are also other markers of macrophage infiltration, but also complement deposition in tubules. So as far as potential therapies, mostly supportive care has been used, but there are different strategies to, for instance, reduce uptake of virus in cells, either by direct antiviral or other mechanism like hydrochloroquine, which we will discuss later. Convalescent plasma is interesting with antibodies blocking virus, but those studies are just beginning. Immunomodulating drugs to prevent and treat cytokine storms, and also include induction of innate immunity. And then the vaccine that will take some time to develop. But mostly repurposed drugs and very few new drugs have been used for this disease. And there are very few randomized control studies published yet. So it's mostly case studies or things like that. The exception is perhaps the lopinavir, ritonavir, Kaletra study that was published in New England Journal of Medicine, showing no obvious effect of this combination for this disease. And this is just to show you how many trials are ongoing as of 27th of March. 726 trials that have been reported, but after looking at this more closely, it's almost 200 trials in this short period of time with different drugs and treatments. So we will know much more in the future. For CKD patients, there are no randomized control studies. Hydrochloroquine, Plaquenil has been suggested of a dose reduction if GFR is less than 30. But you have to be aware of interaction with other drugs and adjust the doses if you use CNIs, mainly cyclosporine and mTOR inhibitors. And lots of people are worried about side effects. But we generally use it a lot in SLE nephritis, and even with people who have bad kidney function. It had also been combined with azithromycin in a French study, which has been criticized for its how it was presented, but they have reported 80 cases now in a new study. So these are things that are used, not that well documented and not done in a proper way that you should do trials, but these are difficult times, so I think you have to accept this right now. One interesting drug is remdesivir, which is a nucleotide analog that has been used in Ebola. However, this is contraindicated if GFR is under 30, and I don't think Gilead will accept studies with the use in GFR less than 30. The other drugs that has been discussed and also used is tocilizumab, which is IL-6 inhibition used for RA and vasculitis. There's been little experience with dialysis, but usually given as a single dose in most cases for the cytokine storm. And then finally, CRRT with the techniques facilitating cytokine absorption has been discussed, and also the use of cytosorb for the cytokine storm. And I just think we can discuss this perhaps later, but this is the guidelines that we have used, discussed in the immunonephrology working group, what to do with patients who have with glomerulonephritis and vasculitis in this context. And our recommendation is to not stop immunosuppressions if patients don't have symptoms. But if they have symptoms, you could reduce immunosuppression, but you have to balance it with the risk of relapse. And then if you have a new patient, relapse in vasculitis, you have to treat them as you would normally. But for GN indications, other GN indications, you could perhaps postpone and use supportive care unless the patient is severely nephrotic or have an increase in creatinine. And this is a big problem with kidney biopsies because it's not possible to do it at the moment at many centers because of the onslaught of patients. But if it's possible, it would be good to do a kidney biopsy if you need it and if it's possible. And then we have said that you can consider postponing rituximab for maintenance therapy. But I suggest you read our follow this link and you can read this for yourself. And for kidney transplantation, similar, if you don't have a sick patient, you shouldn't stop immunosuppression. But if you have a sick patient, you should not stop with all immunosuppression. The reason why they gave this advice from Brescia was that they use Kaletra, and Kaletra is very difficult to combine with the CNI. So, but an interesting fact is that cyclosporin seems to have in vitro coronavirus activity, and it may be perhaps, we don't know that, and not the first thing you would reduce, whereas it's better to reduce or stop the antimetabolites first. If you have very sick patients, you need to discuss it with people in the ICU and infectious disease specialists. So this is just a timeline that I stole from Twitter, but it's pretty good looking at where can you expect effect of treatment. And you have three different stages, basically, the early infection, the pulmonary phase, and the hyperinflammation phase, and you may have to consider completely different treatments at these stages, or perhaps in combination, several treatments. So this is our reality. Do the best you can until you know better, and when you know better, do better. So
thank you, Annette. Thank you very much for that very succinct summary. So I'm conscious that we don't have a lot of time, but just at this point, if I could just ask a couple of questions really to all the panelists, but I suppose particularly to Maria and Umberto, who have unfortunately had the most experience. So we were asked if anybody's used Oseltamivir or Tamiflu. I don't know if Maria or Umberto have a comment about that. Not now.
Yes, no. Okay. I'm on mute. You mean about Tamiflu Oseltamivir?
Yes, we were asked if anybody's been using that. We
have been using Oseltamivir in the very first weeks during the epidemic of influenza, but we have stopped over the last 2 weeks or so. Now we are not using it anymore as a empiric treatment. I mean,
And presumably that's because you've seen no benefit from it.
No, no benefit, no. But the main reason why we started it is because the epidemic here started in the end of February and the beginning of March. And among these cases, there were also cases of influenza. And we could document these cases by performing the nasopharyngeal swab.
Okay.
When in a single run you get all the respiratory viruses.
Okay.
We didn't use in Spain because in Spain the pandemic wave came later on. So we already knew about the experience of Italian and Chinese people, and we didn't use Tamiflu for that, but for this reason.
Okay, thank you. Now, obviously, we know that in some cases the CK is elevated, and there's been reports of rhabdomyolysis. So are you stopping statins routinely in patients?
We stop statins only in patients who start antiretroviral drugs, which include ritonavir, such as Kaletra, or cobicistat, such as darunavir plus cobicistat. Otherwise, we would not stop it. But no, that is not our concern.
Okay, Maria.
We didn't have any rhabdomyolysis patient in my hospital. That we have by now 400 patients in the hospital with coronavirus, so we didn't stop. Only in the cases when we treated with antiretroviral.
Okay, and so I guess again to both of you, when you're using some of the drugs that Annette mentioned, what are you using and why? So Umberto first.
Yeah. You mean the drug that here are most commonly used are hydroxychloroquine and also the antiretroviral drugs.
Okay.
This is for basically almost every patient with pneumonia. Upon admission here on the COVID-19 ER unit, every patient undergoes CT lung scan. If there are signs of viral pneumonia, usually they start the antiviral treatment even before the results of the nasopharyngeal swab. That is what we have been doing so far. Although now in my department we have started using colchicine as anti-inflammatory drug, and we also have we are starting a randomized trial on this.
Of colchicine?
Colchicine, the drug used for gout and pericarditis as an anti-inflammatory drug. Okay.
And are you starting this in everybody with CT changes?
We are starting, usually in the, every patient who is not in intensive care unit, so who is on supplemental oxygen or non-invasive mechanical ventilation.
Yeah.
And usually we wait until they stop antiretroviral drugs, which now are given for at least 5 days or so.
Okay.
So usually we either give one single shot, or we wait until the drug is stopped and then wait 1 or 2 days before starting.
Okay, and then Maria, just before we move on to Paddy, what are you using in terms of treatment in Spain?
And we are using the same, but we are only doing radiography. CT scan is only for patients. The disease is spreading. So we try to do as minimal proofs as we can, as minimal tests as we can. So we are using the same treatment for pneumonia.
Yeah.
And in severe patients, we are using tocilizumab. In real severe patients. And there is a study in Catalonia that they started for patients for contacts, only for contacts with hydroxychloroquine. but it's a clinical trial that they are enrolling now. The patient that has been the familiar that has been in contact
Yes.
with this treatment.
So it's almost a prophylaxis.
Yes, prophylaxis. They are trying this. Actually, they made you call if you are infected, and if you have been in contact with someone, you can be enrolled. The prophylaxis is hydroxychloroquine, and the patient that already has the disease, antiretroviral.
Okay.
The new trial here.
And have you used or have you enrolled any of your dialysis patients, for example, into that trial?
No, not because you know that dialysis patients, we use with them antiretrovirals, hydroxychloroquine, and to some of them tocilizumab. But you know that the trials for them are difficult to enroll our patients in the trials.
In Italy, tocilizumab has been used recently only within a trial. Okay. And for instance, and some patients, and it was very difficult to get the drug recently because of this limitation of the trial. And for instance, kidney transplant recipients cannot receive the drugs because in the design of this study, patients taking immunosuppressants were excluded from the trial.
Okay. So obviously we only have an hour and there are lots of questions coming through, which is terrific. So what I suggest we do just now is we move on to our other two presentations, and then we try and address some of the questions I have written down that you'd emailed in, and then we try and address some of the questions that people have been writing on the chat. So we did have a lot of questions about ACE inhibitors and ARBs. There's been a bit of debate about whether or not these should be being stopped because of the way that coronavirus enters, and Paddy has had a look through the data that we have and is going to offer an opinion, I think, Paddy?
Yeah, I'll offer an opinion. Can you hear and see me okay, and see the slides okay?
We can do, thanks very much.
Right, so I've been involved a little bit in the UK guidelines around these and have some history being involved in stuff with ACE inhibitors and angiotensin receptor blockers. But unlike Maria and Umberto, we in the UK are clearly on the bottom or middle bit of the curve that's about to go up dramatically or starting to creep up. So let me see if I can just get this slide advanced. Good. So obviously this is one of these sort of ridiculous areas of medicine where we as the medical community were having to play catch up on the media based on some theoretical reports that came out. But unfortunately, this comes from the Daily Mail, but also reported in several other newspapers suggesting there was a link between either ACE inhibitors and angiotensin receptor blockers and risk of bad outcomes with coronavirus on the basis of almost no data whatsoever. But absolutely terrifying to have to deal with this in the middle of trying to also practice social distancing and clear reduction in availability to perform normal healthcare consultations. So this came out, and really I think the data around ACE inhibitors, or this at least theory, comes out on the fact that it came very early on in the data emerging from China that of the comorbidities that are all associated with bad outcomes in people with coronavirus or COVID-19, really saw this sort of very dramatic excess, and I've just highlighted it very simply, associated with hypertension. And given that hypertension is a disease that associates with increasing age and associates with other comorbidities, perhaps it's not surprising, but I think it is traditions we see that hypertension is a fairly mild comorbidity, and yet we can see with a very low p-value or a disproportionate effect of non-survivorship compared to survivorship in people with hypertension. So I think people sort of were trying to look into something to see why hypertension was associated with such bad outcomes. Very early on, this letter appeared in Lancet Respiratory Medicine from some people reporting that they thought that perhaps this was to do with ACE expression being increased in people with diabetes and hypertension. Treatment with ACE inhibitors might increase angiotensin converting to enzyme 2 expression, and this might be a theoretical reason why this is played out. So going back to the big science, I'm not going to dwell on this because I think really this is all fairly theoretical at this stage, but papers are flying out and opinions are flying out left, right, and centre. It all comes back to this paper related to SARS coronavirus in Nature Medicine 2005, where in 15 mice, or a series of experiments in 6 mice, so not exactly large trials, clearly shown that animals where the ACE2 was knocked out got some protection from SARS infection in terms of both lung injury and entry of virus into the cells. And in further experiments in the same paper, they showed that losartan may actually be protective. So we're ending up with a lot of theories flying around about whether ACE2 is required for entry of virus into lung cells, and whether once you have virus in the cells, whether ongoing progression of infection happens in the setting of angiotensin converting enzyme 2 or something like that. And I think we really don't know is the honest answer. And flicking through the various preprints that are flying out, have not been able to find anything more than that. So this is a schemata from the Nature Medicine paper showing that there is some need or some interaction between the renin-angiotensin system, and particularly ACE2 and angiotensin 2, in both entry of the coronavirus into lung cells, and there may be ongoing lung injury which may be affected by this as well. Beyond that, well, then we come back to the practicalities of it, and I think we have to look at this and say people on ACE inhibitors often have heart failure, which is a pretty bad comorbidity, or they have chronic kidney disease or diabetes. The same for angiotensin receptor blockers. The pharmacoepidemiology has not been done yet, and therefore any associations need further thought. I think we have to practically at the minute say that these drugs are mainstay for very serious cardiovascular comorbidities. It's almost impossible to safely manage changing drugs anyway in an era when health services are so stretched. Heart failure clearly can present with breathlessness or cough, and that may cloud the diagnostic picture. If we start messing around with the dosing of these drugs now, we may lead to an excess of de novo presentations with heart failure. And I think as nephrologists, we should really recall the story of the association between ACE inhibitors and acute kidney injury, which to my mind is still unresolved, and whether these drugs are associated with acute kidney injury or causative of acute kidney injury is still a debate which is ongoing, I would argue, in the nephrological literature. So trying to blame drugs for severity of disease based on a basic science study of between 6 and 15 mice, and when we have this pandemic happening in front of us is really unhelpful. So what most of the professional societies have said clearly, in asymptomatic patients with a good clinical indication for ACE inhibitors or angiotensin receptor blockers, these drugs should not be stopped, and there's real potential to cause huge harm at public health level, and that comes from European Society of Cardiology, American College of Cardiology, UK Renal Association, etc., etc. What I think most of the guidelines have not come out with, which I think I'd be interested in experience from Spain, Italy, and or anyone else, is what do we do when patients actually come in with proven COVID-19 infection? And it is not clear what to do with these patients. Opinion, or what we're using in our hospital, is use clinical judgment around the hemodynamic consequences. And I've consulted fairly widely with expertise in heart failure and said maybe we should not try and overcomplicate this. And if there's a good hemodynamic reason why you might consider stopping an ACE inhibitor and an angiotensin receptor blocker, that's fine. But if there's a good reason to keep going, then what is the least harm could be done. And I think the other thing we should think about is just looking, and again, the Italian and Spanish experience are interesting, is that we're seeing a lot of AKI in the UK associated with COVID-19, and reports from the end of last week showed that 17% of the patients in ICU requiring RRT. So it's clearly a big issue. So any changes of these drugs might need to be thinking about the renal consequences of this. Just finally, given that healthcare is being overwhelmed, we've got to remember that a lot of the patients with this problem will be being treated by people with non-expertise. So in our local guidelines, highlight the bit in the middle, the panel in the middle right, where it says ACE inhibitors. And for orthopedic surgeons, that's drugs ending in PRIL. Angiotensin receptor blockers, that's for ophthalmologists, that's drugs ending sartan. So it's to try and make sure that we're making guidelines as simple as possible so people can recognize drugs and think about what to do about them. And we've suggested, similar as you might use for AKI, if people have hemodynamic upset, consider discontinue. Similarly, if they've got actual acute kidney injury, but also remember reviewing the indication why people are on these drugs. And also in survivors, it may be worthwhile thinking about getting people back on these drugs promptly if they've stopped, because what we don't want in this pandemic is that we have some survivors and then 6 weeks down the line we have people being readmitted with heart failure, which is what happens after acute kidney injury. So I think this is all moving so fast, and more data and pharmacoepidemiology will emerge. This is really tough. And I would refer to this article, which seems to have been authored essentially on Twitter, but it's a fantastic article reviewing the debate. I refrain from putting all the pictures from this in, but I think this came out in CJS maybe a couple of days ago, and it's a fantastic article, nice diagrams highlighting the debate and some of the basic science in there. So probably refer you to that, and I'll hand back to my colleagues on the rest of the webinar. Oops, exit.
Thank you very much, Paddy. That was a very clear message that we shouldn't be routinely stopping these medications because patients will end up being at risk. But also, I think a very important point that the field is rapidly evolving, so we do need to be careful that we're keeping up with what is happening. So I'm now going to move on to Maria, who's going to tell us a little bit about what's been happening in Spain and share her experience. There are lots of questions coming through, which is terrific, and I promise when Maria has spoken, I will try and work my way through as many of them as is possible. But again, we are going to run a couple more sessions, so hopefully we will get through all these questions. I know people are keen to hear about people who are living this every day, so Maria and Alberto. So Maria, thank you. If you could share your screen with us.
Can you hear my? Are you able to see my screen?
Yes.
And to listen me?
Yeah, we can see you and we can hear you.
Okay.
Thank you.
I would like to thank you for inviting us and for organizing this in this tough time. Thank you, Kate, because I know that it was difficult to organize us now. And I'm sorry because Nuria cannot be here because she's working with COVID and we have a lot of patients and people in the hospital are really busy now. She prepared the majority of the slides that I'm going through. I cannot pass. Okay, so our first case in Spain was at the end of January, and you can see here, this was in Canary Island, in La Gomera, and was a patient that was not from Spain, was a tourist from Germany. Our second case in Spain was the 10th of February, and was also a British tourist, British, from Palma de Mallorca. And our third patient, and the first patient that died from COVID in Valencia, was a patient that died from a pneumonia, and the diagnosis was performed post-mortem. It was a patient that traveled to Nepal. And the 13th of February, he died. So, the Spanish experience is that we decided in Barcelona, people was really upset because we decided to cancel the Mobile World Congress. I think that this was a good step. But after that, the manifestation of the woman was not cancelled, and it was in March. This was horrible because I think that this was one of the parts that the people get a lot of the disease. And a football match. Our people from Valencia, our soccer players from Valencia had a match versus Atlanta in Milan. in Milano. So I think that these two help to spread the disease in Spain for sure. In Spain, we have 3 variants of the disease, 3 different backgrounds. One from England, as you can see here, the other one from Hubei, and from China, and the other one that is from Valencia, Genova, Italy. So we have 3 different variants, and we know which people, because the majority of us are not tested for that. Here you can see yesterday's report is for Mrs. Kerring, this report. Yesterday we have a total of 72,000 patients, more than 72. The total death was 5,000. And on the right, you can see the daily deaths. So we need to stop that. People should stay at home. And yesterday in Spain, it move on, and the majority of work you cannot go, only work for foods and healthy works. And 16% in healthcare professionals in Catalonia have the disease. And I think that is because we only are testing people with pneumonia and doctors that are treating patients. So I think that the disease is already much more spread than that. Here in the next slide, you can see the incidence. And the worst incident is in the Madrid and the surroundings of Madrid, and in places really crowded of people. And as you can see, Barcelona, Catalonia, as a part of Catalonia, is actually growing up. This was data from 2 days ago. And here you can see the evolution of the patients. In blue color is going really up, the patients that are in the hospital, but at least I'm a little bit happy because the recovered patients are going up in green color. As you can see in Spain, the patients are recovering a little bit, and we are discharging patients to the home. Here is the Spanish experience with the age, and we think with Nuria that is the same that in China, the lethality by the ages. The difference that we have in Spain is that a lot of people is old. So we have a lot of old people. Spain is currently was, I don't know how it will be after this pandemic, but was the second place with older people after Japan. So we have a lot of people older than 80 years. So, but the mortality, if you are following the ages, is the same that in Japan, in China, in the China experience. So I will show a little bit the experience of our hospital. Hospital del Vallebron is a hospital, a university hospital, one with 100,000 beds. That is a lot. All of the medical and surgical specialties. We are the referral center for most pathology, rare disease. We have renal, liver, and lung transplantation for adults, and for children also, but also heart in children. So you have the feeling that this is a really big hospital. Here you have the patients that were admitted with COVID, starting by the day 12 till yesterday, and you can see a lot of patients in the hospital with COVID, but and in the right panel, you can see the patients in the intensive care unit, and this is exponential. We started by 17 patients, and 3 days ago we have 140 patients. We are planning to have around 300, more than 300 used beds in the hospital, because 260 intensive care beds, because we need them, and we are planning to have them in a few days. We are growing up really fast because we need this kind of beds. So let us talk a little bit about dialysis and transplant. This is our experience from my unit. So we had 12 patients in dialysis. The first patient came out the 11th of this month, and this patient is currently in intensive care because the patient came with a severe pneumonia. And we have 13 kidney transplant patients in our hospital yesterday. This is the data from yesterday. The mortality was 3 of our patients in dialysis diet and 4 of our kidney transplant patients. One patient now is in the one that I already told you before. She's in the intensive care unit, and 2 patients from kidney transplant. And we have to say that we are happy because one of the kidney transplant patients was discarded and actually is at home. We have a problem with the hemodialysis patients because we tested again them, and 2 of them that were really good and they could go at home, they could not go at home because they are positive. They didn't, so we cannot send them because we are not prepared for the dialysis center. I think that tomorrow or in 2 days, we could send our patients to a dialysis unit, and maybe some dialysis patient will be also discharged. This is the experience of the Spanish registry. I have to say thanks to Emilio Sanchez that he gave me this data yesterday. Today is already published. And the registry started 10 days ago. 45 centers for Barcelona collected the cases, and currently we have 234 patients from Barcelona, dialysis and transplant patients. Here you can see the registry, the percentage of the registry, but this does not mean we have to wait that people finish the registry, but people is collaborating. As you can see, in only 10 days, we already have more than 200 patients registered. How do we have from that? We have the majority of them are hemodialysis patients, 68% of the patients, only 5% in peritoneal dialysis, and kidney transplant, 26 patients. The mortality percentage of all of the patients is 21%, but I was surprised to see that 44% of the patients were on hemodialysis therapy. So I think that these are older patients, and for that, they death more than the other. 4% of the patients were already good, recovered. Here you can see the symptoms of these patients. We will have the data separated later on, but now it's for all of the patients. And you can see 77% the patients have fever, the majority of them. Lymphopenia, the majority. Cold, rhinorrhea, sore throat, 67% of the patients. Dyspnea, 33%, and asymptomatic only 7%. But I think that the patients that do not feel the disease are not tested or are unknown for sure. So maybe this data is not really 100% the asymptomatic patients, but these were the patients that reported and that were admitted to the hospital. Here do you have the treatments, and I am already finishing. And 75% of the patients received hydroxychloroquine, lopinavir and ritonavir, 47% of the patients, steroids, 15%, interferon, 11%, and tocilizumab, 3% of the patients. Thank you very much.
Thank you very much, Maria. Thank you to all of you. So we have a lot of questions here, so I'll try and work through them in a logical order and put them through to our panelists.
Can I just ask one question to both Maria and to Umberto about
Sure.
lopinavir and ritonavir? Because after this New England Journal of Medicine publication, do you still use it, or do you think it's a good idea to use it in patients, in our patient population, since it was a negative trial? Do you still see an effect? What is your experience?
In our region, we have guidelines that are in the hands of infectivologists. And after the results of the New England Journal of Medicine trial, they changed those guidelines in a way that now we have a risk stratification of patients, and in patients which are in the moderate to severe disease, you have the option of starting hydroxychloroquine and or antiretroviral drugs. In most severe patient intensive care unit, those are not mentioned any longer.
I have the feeling that, and I reviewed this paper. I reviewed this paper, and I have the feeling that this paper, in this case, in the New England, the drug was started late when the patient was already severe, because the mortality rate was around 18%, when the mortality in China is lower. So maybe the drug is good, but when you start early. So we are giving the drug, but not maybe in intensive care. We are giving the drug earlier on. Because if you look at the patients, the majority of them were really bad with a high Apache score, and they are the really bad, the patients that were going worse.
Okay, thank you. So there are a lot of questions about treatment and how you're treating people and at what doses you're using these medications. So to all of you, what dose of hydroxychloroquine are you using?
The dosage in Italy still, the standard dosage is 200 twice a day, 200 milligrams. Some people start with a loading dose of 400 milligrams the first day, but most people receive 200 milligrams twice a day. Although I know that there are other possibilities, like giving 3 times a day and other regimens also.
Okay, thank you. And Maria, is it the same?
For dialysis patient, we reduce the dose.
Okay.
One each 2 days for dialysis patient, and when you have GFR between 30 and 15, sometimes it is recommended once daily.
Okay. And we've also been asked, what is the proposed dose and protocol in the prophylaxis trial? So the trial that you mentioned, Maria?
The prophylaxis trial is twice daily, but I know that the trial is ongoing, but I didn't have the opportunity to read them all.
No, that's okay, thank you. Are you doing ECGs on these patients, and are you noticing a lot of side effects? Maria, Umberto.
Doing, what do you mean? Doing what?
So are you doing an ECG, so an electrocardiogram on these patients that you're giving hydroxychloroquine to, and are you noticing?
You mean, yeah, yes, every patient who is admitted for pneumonia receive EKG, of course.
And
yes,
what about when you're giving them the hydroxychloroquine?
Because of, you mean the QT prolongation time?
Yes.
I would not see that there are not, it is just, there is a warning about that, but there are no criteria to exclude patients based on the length of the QT interval.
Okay. So in terms of other treatments, we're being asked if anybody has any experience of azithromycin.
Azithromycin, usually every patient receives antibiotics, okay. And this is always given to patients. Every patient with the viral pneumonia receive usually antibiotics with azithromycin, but also ceftriaxone.
Okay, and Maria?
In Spain, we are using more azithromycin because there are some studies that suggest that may be good also for COVID. But if you have actually enlarged QT, we do not recommend the combination of hydroxychloroquine and azithromycin because you could have a torsade of points, and we do not recommend in that case. Okay. And you asked for secondary effects, and Caletra in our transplant patients is giving a lot of diarrhea. So sometimes we have to stop, to withdraw the treatment for diarrhea. I don't know if you have this experience, Umberto?
Yes, it is the same for us. It is often causes diarrhea, yes.
Okay.
I just want to say about azithromycin, because there will be more discussion about that, but it also has been it's suggested that it has some kind of anti-inflammatory effect and not only antibiotic effect, and that's why it's interesting. that's why it was brought up. But it's used. That's how they started to use it as an antibiotic, and you have to follow the literature and the studies that are coming forth now, because they will be. We will know more about
Yeah.
this combination.
So Annette, when you were talking, you mentioned the use of Cytosorb. Would you say that this would apply to all dialysis patients? So
Yeah,
both an acute kidney injury needing RRT and also chronic patients?
yeah. So Cytosorb is very expensive, maybe not so easy to find. I think that we have used it in 2 ECMO patients with a big effect on the cytokines, but it's just under special circumstances. I usually don't work on a daily basis in dialysis, but perhaps there are other techniques or that you could use in the ICU department. So Cytosorb is, I think, for specific situations, and perhaps these anti-IL-6 treatment is something that will be used more, especially with more knowledge from bigger studies from Italy. I think there is an ongoing study that's going to recruit 300 patients with tocilizumab that will be finished by May, I think, or middle of May, and then the endpoint is mortality at 1 month, and there are no controls, but historic controls. They will have to use historic controls. So perhaps for practical reasons, it may be better to think about the medication of reducing the cytokine storm rather than Cytosorb. But if you have the opportunity, that's tocilizumab. You could perhaps consider Cytosorb.
Okay, and then Umberto, one more question for you just now, and then I have 2 questions for Paddy. How are you dosing the colchicine in acute kidney injury or dialysis patients?
Dosing, you mean? The dosing for transplant recipients, it is you have no issue of major issue of interaction in our patients, because usually they we have no problem with the tacrolimus interaction, some problem with cyclosporine interaction, but usually cyclosporine, if given, is given at very low dosage. Usually the standard dosage is 1 milligram per day, but we tend to decrease to 0.5 if GFR is below 30. In dialysis patients, we give 0.5 every other day, usually after the dialysis session.
Okay, thank you. So Paddy, I'd ask you to comment on this, but obviously anybody else is welcome to pass comment. Do you have any opinion, I know you will have an opinion, about the BTS guidelines suggesting that the anti-proliferatives be stopped in all transplant patients with coronavirus, irrespective of severity?
So I don't actually have any opinions on that, because I don't think we've got enough experience of that. I mean, there's some data coming out of China, and I'm sure well, Umberto will know far more about this than me, because he's an expert in transplantation anyway. So I just don't know, because we don't have those data. I'd be interested in what Umberto does with transplant recipients, in all honesty. Umberto, do you stop anti-proliferatives in transplant patients with mild coronavirus, who are able to manage at home?
So basically, we have this kind of approach for the patients with very mild symptoms. We usually usually stop the anti-proliferative mycophenolate or mTOR inhibitors. For mild symptoms, we mean those kind of patients who are followed up entirely over the phone. We have this kind of patients because those patients should not access directly the hospital, and sometimes they are visited by their own GP, and we follow them up on a daily basis of the phone. For mild disease, I mean patients who have less than 38 degrees of temperature, who have only mild flu-like symptoms or gastroenteric symptoms. I don't mean patients who have dyspnea, cyanosis, or persistent chest pain or worsening cough. Then we follow them up over 3 or 4 days, and if things do not clearly improve, then we consider hospital admission or reduction also of the calcineurin inhibitor. For patients with severe pneumonia who are admitted to the hospital, we usually stop calcineurin inhibitors, but this is a compulsory decision because they usually start antiretroviral drugs even after the findings of the New England Journal of Medicine paper.
Thank you, Umberto. So we've been asked about steroid use. So obviously in some coronaviruses, there is evidence that steroids have no benefit in these patients and perhaps maybe detrimental. So are you using steroids in your patients?
We usually continue steroids in every patient, and also consider pulse steroids in those patients whose respiratory condition are worsening and they may require intubation. Then because of shortage of ICU beds, there are problems concerning the transfer to ICU. So we consider them. I do not strongly believe in this kind of literature that they are detrimental in this kind of condition, this kind of selection bias. We would need randomized trial to address whether or not steroids in this setting are
the UK recovery trial, which is just launched, does have a steroid arm in it, so there will be proper data will come out on the use of steroids, but everything else is.
Yes, I mean, in this patient whose respiratory condition are abruptly deteriorating over 48 hours, you do not have tocilizumab, you do not have anything, you do not have the bed in an intensive care unit. I mean, in this case, I think you should consider. And I believe that one of the reasons of the high mortality is because of the shortage of beds at intensive care unit. So sometimes you have to consider any option.
Yeah, okay. So I'm aware that time is ticking on, but we do have a few more questions if you can spare us an extra few minutes. So a lot of questions around the logistics of managing the dialysis units. So what you're doing with your patients who are infected, so I guess to Maria and Umberto mostly, and how are you managing the patient coming from household for somebody else that has the disease or has symptoms of the disease? So Maria, would you like to go?
Actually, we are lucky because we have a dialysis room inside of the unit. And one in our unit rapidly was transformed in a COVID unit. So we keep one room and patients are going in and out, and the dialysis unit is apart. It's a room for they have waters and all of the stuff for doing dialysis. But I think that if we will have more patients, we will have to use the one used for virus, for C virus, or for other kind of virus patients, only for COVID patients. From now, we are managing that way. Okay. But for sure, you need at least 2 meters that the nurse is well covered with the FP3, 2 meters at least, and not doing a lot of stuff with the patient if the patient is okay. We had a problem with more than one patient because they have back pain when they were doing dialysis. I don't know, Umberto, if you experimented the same?
Yes, we have the same experience, a similar experience. We sectioned off our hospital dialysis unit, so a plaster wall was built in the hospital dialysis unit to separate completely COVID positive from COVID negative patients. So we have different personnel, healthcare personnel, and everything is separated, the entrance and the exit. We converted those limited care dialysis center in the periphery into COVID positive and COVID negative centers. And we have a triage for patients who are coming to the hospital to verify whether they had any symptoms suggestive of COVID infection. Nonetheless, we had 2 patients who started the sessions and we discovered that they had some symptoms of the disease. So that is something that it is very difficult to manage, but I think it is improving. But I must say some, in general, I would like to say something more optimistic. Now, thanks to all these lockdown strategy that in Italy has started since March 11th, 13th. Now the epidemic here is leveling off. Now the number of new cases is decreasing. The number of cases in Italy is 1,000 less than a few days ago. We had less admission to the hospital and over the last few days, and less pressure on the intensive care unit. So I think we had many kind of problems with our organization, but things now are improving.
Okay, that's certainly very good to hear. So in the United Kingdom, as well as in a lot of places, there's been a bit of contention surrounding the use of PPE, particularly in dialysis units, so face masks is what I'm referring to. Are you wearing face masks, so all of your patients in the dialysis unit, regardless of whether or not they're infected, and are the staff all wearing face masks? So I'm just talking a basic surgical mask.
The basic surgical mask, usually every person of the staff is using. Of course, in the COVID positive patient, they use the FFP2 or FFP3 mask, and they have goggles and the face mask and all the protection equipment that is required for this kind of patients. However, the surgical mask, basically every patient and nurses
wear them.
Wear it.
And is that the same in Spain, Maria?
It's the same, it's the same.
Okay. So if you don't mind, we've had a lot of questions about acute kidney injury, and I think a lot of these stem from the fact that places are unfortunately watching what's happened in Spain and Italy and are now trying to plan as best they can for when the peak comes to other countries. So people are wondering about the incidence of acute kidney injury requiring renal replacement therapy. And those who need ventilatory support, so those who are being admitted to intensive care essentially, and how long RRT is required in these patients. Now, I guess you may not have exact numbers, but do you have a feel for how much acute kidney injury needing renal replacement therapy you're seeing?
In Parma, we kept the same indication as usual, and with those indications, we had not that many patients requiring renal replacement therapy in the intensive care unit. I guess there were basically 6 out of possibly 100 patients in the intensive care unit. Okay. So we usually, because of mainly logistic reasons, we do intermittent dialysis. SLED, we use sustained low efficiency dialysis for 8 to 12, sometimes 16 hours. Yes, it was not a major issue in those kind of patients. Yes. Although there are many patients who are in such severe condition that sometimes they are just withdrawn from every
treatment. What about the proportion of patients who maybe step down from intensive care still needing renal replacement therapy? Did you see much of that?
Among those 6, 2 died. Yes. One now is not requiring renal replacement therapy.
Okay, and Maria touched on this in her presentation, but in Italy, how many dialysis patients, so end-stage renal disease patients, did you see who required ventilated?
So we have, in our area, we have about 250 hemodialysis patients, and we had around 30 patients we were ended up to be COVID positive, and only 2 were admitted with pneumonia and did not require the invasive ventilation, they only required oxygen. One was discharged, and the other one is getting better. So we did not have among chronic hemodialysis patients any severe case of pneumonia so far, but we had at least we had 6 deaths for patients who in a way did not were not managed neither in intensive care unit nor in our unit. We have an intensive care unit in our nephrology department, and also in this unit a plaster wall was built, so we have the possibility. We have one clean section for acute patients who are COVID negative, and another section for patients who are COVID positive. So here in Parma, you can be transferred to intensive care unit, or in our unit if you have severe pneumonia. And so those patients who died were very old and didn't were not admitted to those units.
Okay, therapy and acute kidney injury.
The problem is the same, that we have very old patients. We have old patients that sometimes they are not admitted. If you have 85 years old on dialysis and you came with a severe pneumonia, there is no way to be in the intensive care now or before the COVID. So these patients, some of the patients that died were because they have a severe disease and they were not accepted in an intensive care unit. Another thing that I would like to share is that we, in one of our patients with acute kidney injury, we use not Titosurf, it's not Oxiris. I don't know if you have experience with Oxiris, but this was really good, and the interleukin 6 levels were really going down, and the patient was a woman who was really sick before we started this therapy. This may be another option.
Okay. So I think we probably have to start thinking about bringing things to a close. You've given a lot of time, but I'd just like to ask, there's a couple of other questions. Let me just find them. So Arvin Kanchi has asked data on how patients from different nationalities are affected. So disease incidence and mortality he's talking about, particularly from nations that are regularly using the BCG, like India and Bangladesh. I suspect the answer is that you may not, but it's an interesting point.
I just want to explain why you do it, is to improve the innate immune response, and that would be more like a short-term response, I think. So if you had the BCG vaccination as a child, you may not be protected. That's not the point of the trial. It's a short-term protective effect.
Okay, and then one very final question. So the value of serological tests, does anybody perform tests to evaluate seroconversion in positive PCR patients? And do you know then if seroconversion would confer protection from reinfection?
In Italy, the serological test is not available in every center, but I've read about some data that shows that the accuracy of this test is rather poor. Sensitivity is 40%. I cannot say anything about the relation between this test and the protection against reinfection.
Okay, thank you. Maria?
We need more data. I don't have any when the patient is well, the patient is the same. And you don't know if you are after that protected. We don't know IgGs. There are some studies, but we need more time. I think that is a really new disease, only 3 months ago, 2-3 months ago, and we don't have yet this information. This should be good to have because for the future, I'm looking at a future with a kidney transplant again, because in Spain, the kidney transplant program now is stopped. So in a future, we will not to know if the people is COVID protected, not COVID protected. I don't know, Humberto, as a kidney transplant, what do you think about that? Or if your mind is thinking in that?
I have no idea whether people is protected or not. Intuitively, I would think that that is the case, but we have to see.
I think just for the antibody test, I think in Germany they are, have been able to test in different locations, and I think we will have results from them pretty soon. And I think they have good assays. So it really has to do with getting a good assay that can tell us really what the situation is, and then it will be used for many more patients and also for people in healthcare, because it's really important to know who can work and who cannot work and who has to be extra careful.
Yeah, and IgG tests would be helpful. No, there's no doubt about that. So I think we have to bring things to a close. There are still many questions we've discussed that are not answered, and there's many questions coming through that we've not had the opportunity to ask. I think the experience in different countries is very different, and I guess we just have to wait for more data to be published, and I think we're all learning as we go along. We are having another of these sessions on Friday with a different set of panelists, and hopefully we'll be able to cover some more of the points that you're all raising. But I'd like to thank Paddy, Maria, Humberto and Annette very much indeed for giving up their time, particularly when some of them, as I say, are not well and some of them are really working exceptionally hard. So thank you very much indeed. That was really very, very helpful and very kind of you to give your time.
Thank you.
Okay. Thank you very much, everybody. Take care.
Thank you.
Bye-bye.
Bye-bye.